know in prostate cancer that it's a hormone-sensitive disease, and when we first treat prostate cancer, we treat it by taking away hormones. We deprive the patient of testosterone by turning off the testicle producing testosterone, and we give additional drugs that block testosterone like enzalutamide. So initially the cancer is very sensitive to those approaches. The cancer shrinks, the patients do better, but over time the surviving cancer cells that aren't killed by that treatment adapt to the new environment they're placed in with very low testosterone. And one way they adapt is they start to make more and more of what's called the androgen receptor, which is the target of testosterone. It looks like to us they titrate the androgen receptor up higher and higher till they find a level that they can now start to grow again. And that high titration causes resistance to the treatment, but it seems to make them vulnerable to high testosterone. So they don't like, the cancer cells seem to not like very low levels, and they don't like very high levels. They sort of like a kind of Goldilocks middle level. So we're trying to take advantage of this adaptive ability of the cancer and either treat it in different states with these two different treatments, which are the opposite of each other, really. So previously we've done some biopsies to look at changes in the androgen receptor, which gives us a lot of great information, but it's difficult to do for a patient to biopsy them repeatedly. So we were looking for a different way to do this more dynamically. So there's a new technique that's emerging called measuring circulating tumor DNA. So the cancer will shed, and when it dies, pieces of DNA go into the blood, and we can detect those. So what we decided to do is look for the androgen receptor DNA in the blood. And we can do two things. We can see if we can detect mutated androgen receptor, but we can also look at, because it's DNA, how many copies of the androgen receptor are in the blood. Normally you have 2 copies. Everybody has 2 copies of each gene, but under pressure of depriving the cancer of testosterone, the cancer responds by making many copies. So it may have 20 copies of the receptor, and we could detect that. And so we developed this assay to detect, well, we can look at all kinds of mutations, but the mutations that seem to be most important for this treatment were related to the androgen receptor, both the mutations and then how much receptor was there. So I will say it's a simple test, but it's really complicated, but simple. It's emerging as kind of probably going to be a standard blood test that patients will experience with their cancer treatment, not just for prostate cancer, but across all cancers. So the vision would be you would do a test and you would see the level of the androgen receptor DNA. And if it was low, you would say, okay, the next treatment should be more androgen blockade. And if it was high, you would think, well, maybe we need to go to high androgen. And then we could follow the patient, and at some point it would switch, so the high androgen would go low, and that could be a sign to switch treatments to from high to low. So we're doing a study right now where we're kind of looking at that. What are the dynamics of it as we treat with high androgen or high testosterone? How quickly does it switch from a high to a low, and vice versa? When we treat with enzalutamide or an anti-androgen, a blocker, how quickly does it switch the other way? So we think it might be a good way to almost individualize treatment for people, where we can sample their blood over and over again. And some people might stay on the treatment for a year, and some people might need to switch in 2 months, depending on what happens with their cancer. The biggest thing is just getting more numbers and more samples and more sampling times. So the study that I presented here at ASCO, we really just looked at 2 times, kind of the pre-treatment and at some point post-treatment. I think what we'd like to do is maybe sample patients every month and start to get a feel for, when does this start to, these changes, how quickly do they happen, and how often do they happen, and how often do we need to do the testing. So I envision it's going to really be doing more testing to really nail down what's the best way to do it, and what kind of levels do we need to see of change. Is a little bit of change all we need, or is a lot of change, things like that. I think again, this is a new type of treatment, and a lot of patients are doing this treatment on their own, And so we've wanted to stress with our approach that although it seems like this is very safe, men should be careful that if they have any pain from prostate cancer, they probably should not do this. And this treatment is also designed for men who've become resistant to standard hormone treatment. So if they haven't had hormone treatment yet, they should not be doing this treatment. It's really a timing kind of thing. So those are really for any patient who might be looking at this, story that they need to talk to their doctor and kind of get some information about what's the best way to do it.